Guys, can you now see the PowerPoint presentation I shared?
Yes, doctor.
Okay, very good.
Yes, doctor.
And can you see my mouse?
No. Oh, yes, it appears
Yes,
now.
it is visible now. Yes.
All right. Okay, so just because I'm using it. So last time we already started with this chapter. Okay, so remember we started, we're going to talk about cholinergic agonists. Okay, and we said we have some that are direct acting and we have some that are indirect acting, right? And for those, we have this. Do you remember what this did? Direct acting, what they did exactly? So we agreed that direct acting was the one that acted directly on the receptors, and indirect acting were the ones that acted on the enzymes that broke down acetylcholine. Okay, so today we're going to mainly focus on the direct acting. Last time we talked about the receptors. So we started with the nicotinic receptors and we said what those are. So those are ligand-gated sodium channels, if you remember. And we talked about in details what they did. And muscarinic receptors in details we talked about, and we said we have the odd numbers and the even numbers, and both of those depend on the G protein and the alpha subunit of the G protein, if you remember. Okay, so that was where we started. So guys, these tables are extensions of what we talked about last time. Okay, so if you remember what we talked about last time, the mechanism of action, so this is mainly it. Okay, what are we responsible to know? So, okay, so we talked about the effect of those, all right? Remember that the odd numbers, they were present usually to excite, and the even numbers were there to inhibit, like for example, in the heart, okay? So where the principles locations are, we already memorized those in the different tables, so there's no need to focus on those so much. Whereas the signal transduction is what we talked about here. So remember the IP3 we mentioned before, right? So this is IP3 over here. Okay, and for example, potassium efflux. There you go. This is potassium efflux. And what else? Cyclic AMP. Remember, cyclic AMP was here. So guys, it's enough to memorize this, and whatever is in the tables over here is just extensions, applications of what we have. Okay, so you start with memorizing this one and move on to the tables to apply whatever, just to make sure that you understood those. Okay. So we're going to start with the direct acting acetylcholine receptor agonists, and those are the drugs that act directly on the receptors. Okay, and they are what? They are agonists. Okay, so we're going to differentiate between those and the forms of what they are, if they're natural, if they're modified, and if they're completely synthetic. Okay, and we have to agree on a few things. The number one thing we have to agree on is that we have to differentiate. We talked about those as acetylcholine receptors. So the next question comes, do these drugs act on muscarinic receptors or on nicotinic receptors? Okay, guys, do you remember what we said previously? Which one do we want and which one do we want to avoid, muscarinic or nicotinic? What do you think? Anyone?
If you are talking about the sympathetic, it's gonna be the nicotinic, right?
Over here, we're talking about parasympathetic. Sympathetic is alpha beta. Parasympathetic is nicotinic muscarinic, right?
We want to avoid muscarinic because it will affect all the muscles, like
Excellent.
in smooth muscles.
In skeletal, not smooth muscles. Excellent. Okay, so listen, guys. When we talk about muscarinic receptors, all right, this is what we want. This is where the effect is. But the nicotinic receptors, most of the nicotinic receptors, they're present where? Either an N or an M. So, that's not what we want. Do we want to activate all muscles? We do not want that. Do you want to activate all ganglia? The NN all ganglia, like in sympathetic, parasympathetic? We also do not want that. For that purpose, we are not going to want to target nicotinic. So the best drugs are the drugs that can act on muscarinic receptors, all right? Whereas the other thing that we want is, do these drugs get hydrolyzed? The drugs over here, do they get hydrolyzed by the enzyme that breaks down acetylcholine? Some of them does and some of them don't. Okay, so guys, again, a next question. Do you think if these drugs are hydrolyzed, so they're broken down by receptors, by enzyme, do you think they're going to be short acting or long acting, or will they be acting for a long time or for short time?
Short time?
Excellent. So if they're being degraded, 100%, if they're being degraded, that means they're going to act for short time, right? But if they're not degraded by the enzyme, that means they're going to last for a long time, all right? And which one is better? You're going to ask us the question, what do we want from them? Okay, so if we want to treat a person, we want the one that is long acting. But if we want something that can diagnose a case, okay, sometimes drugs are used for diagnosis. I don't want something that can last for days. I want something that can last for 5 minutes. Okay, so let's take a look at the drugs. So do we want the structures? Of course not. This is you're going to learn in medicinal chemistry. So take a look at the table over here. So the table is simple. So what do we want from this one? So let's take a look. Acetylcholine. Acetylcholine, does it get hydrolyzed by acetylcholine esterase? Well, of course, it's at the end acetylcholine, right? The second question is, does it have any nicotinic activity? Well, of course, it does act on nicotinic receptors, but because it's acetylcholine, okay? Now, methacholine, does it get hydrolyzed by cholinesterase? Slightly. Well, it does, okay? So do you think that the duration of action of both is going to be long or short for those?
Short.
100%, thank you. And for the nicotinic activity, which means, do they bind the nicotinic receptors? Yes, they do. They bind the nicotinic receptors. Do you think this is good or bad?
Bad, because
Do we want? Yes, thank you so much. So, yeah, this is also bad, okay? So, guys, carbachol and beta-nicole, do they get hydrolyzed by acetylcholinesterase?
No.
No, they don't. The duration of action then is?
Long.
Excellent, is long. Okay, and carbachol can have nicotinic activity, so it's not good, okay, for that purpose. So we cannot use it for treatment because it acts on the nicotinic receptors. So guys, we're not gonna use it as a pill, okay, never. Whereas beta-nicole, it has the perfect combination for treatment, long duration of action, and it doesn't bind to nicotinic receptor. Same thing for the other two drugs over here, okay? So this is an explanation of what we talked about, okay? So guys, listen, sometimes even if the drug, for example, binds the nicotinic receptors. Okay, so we agree that we cannot use this for the whole system. So the question comes, what do I do? One of the things, for example, that we can do is we can use something called pharmacokinetic selectivity. What is this? This is exactly, for example, instead of using it, for example, as a pill for the eye, I can use it as an eye drop. In that case, I don't have any side effects to the system, okay? But what's happening in this case? We're giving the effect only to the eye, okay? So we're avoiding nicotinic receptors, and this is what we want. Is this clear, guys? Are you all listening?
Yes, it's clear.
Very good. Do we have everybody awake? Okay,
Yes.
thank you for responding.
No.
Of course not. Guys, just to make sure, everyone, press the raise your hand button, please, on top. I want to see everyone who's awake. Yeah, let's do a test. Don't cheat and text everyone. Good morning for the rest of the people who are still sleeping. Wallahi, online sessions are the worst, especially in pharmacology. Yeah, we have some people still sleeping, 100%. But guys, make sure that you come on campus because other professors are having regular courses.
Will not be attended.
Who's talking? Cannot see. Who just talked? I did not see the name.
It's me, Mustafa.
Mustafa? Okay. All right. Let's see how things go. Yeah, let's continue. All right. Can you see my slides again?
Yes.
Okay, amazing.
Yes,
So,
we do.
very good, very good. Okay, let's agree on something, you guys. When I have a drug that I say is positively charged, does it mean that can it be absorbed or can it go into the central nervous system?
No.
Exactly, okay? And this means for the drugs that are ammonium compounds, okay? Let me see if this structure over here. So guys, can you see this structure? You see this positively charged over here? This is an ammonium compound. When they have this structure, this is called an ammonium. This is a nitrogen with 4 bonds, okay? And it's positively charged. That means those drugs cannot be absorbed. So number 1 rule, can we give them usually orally?
No, it orally
Okay,
will
no.
not be approved.
Exactly. So usually I give them in the form of injections or other forms. They can barely be absorbed, okay? Sometimes. But in other drugs that over here are not quaternary, so they're not positively charged, like this one and this one, okay? These are drugs that are tertiary ammonium compounds. So those are 1, 2, 3 bonds, okay? Which makes them good drugs to be absorbed in the system, okay? So those drugs are that can be taken orally. Okay, so quaternary ammonium compounds are poorly absorbed and not distributed to the central nervous system. Okay, let's start with the drugs one by one. Okay, so starting with acetylcholine first. Acetylcholine is rapidly hydrolyzed by cholinesterase. This makes it having a very short duration of action. We agreed on that. Because it's acetylcholine, it binds, it's both nicotinic and muscarinic receptor activators. Does it have very wide clinical applications? No, it does not. It has very limited clinical applications because it has a very short duration and it binds to nicotinic receptors. But what are we going to use it for? We use it for two reasons. Okay, so guys, can we together write the set of, I'm going to create a new slide, and together let's write the effects that are because of a cholinergic or of a muscarinic agonists. You know what? Because we're sleepy, let's try to write those in groups. Okay, so let's write the effects of those from the tables. So what happens to the eyes, what happens to the vision, what happens to the heart. Let's try to work on those in groups. Okay, so you can write those down and then we can discuss them again when we're back. So guys, I'm gonna create breakout rooms for people. How many people do we have here? We have 36 people in the meeting. Yeah, guys. Okay, so you know now what we will do? Guys,
Can you say it again?
okay, so now we're going to create rooms for you to go and work with people. What we're gonna do is that, because you're sleepy, what we're gonna try to do is we're going to try to write down what are the possible effects of muscarinic receptor agonists. Okay, so what's gonna happen to the eye, what's gonna happen to the heart, and all of those. Okay, just in the form of practice. So guys, I know you're not in the mood, no one's in the mood. Okay, but let's do our best to finish this session, okay? Yeah, I'm gonna open the rooms now and you have some time and I'm going to return you in a bit. Try to have a list of what the possible effects are, okay? Because the rest of the lecture will depend on this. Farah? Basma, are you okay?
Oh, yes, I am fine. Sorry, sorry.
Because you're outside the groups.
Oh, no.
Do you want okay. Hi, Dad and Shahad. Good morning.
Good morning, Dr. Rana.
Why aren't you with your friends?
Because now
You join now?
attend class, yes.
Yeah. I assigned the rooms for you, so you can go. Hi, Dad. Good morning. Guys, you're back in the session. Okay. So did you make a list? I think I gave you time enough. Okay. Now I want people to help me out in writing that list because I'm gonna write it down over here. Okay. Now, let us start by asking people. Okay. Let's go one by one. So, I saw Abdullah, you were clapping. Can you help me out with the first one? What happens to the eye? Pupil.
Meiosis.
Excellent. Meiosis, that's right. All right, so what happens to the heart? Yalla go, Muhammad Aqib,
Decreased
you're
heart
raising your
rate.
hand.
Decreasing heart rate.
Yes, that's totally correct. Thank you. So what do we call this? Bradycardia.
Hypertension.
Bradycardia.
Bradycardia, right? 100%. Okay, what happens to the vessels? Blood vessels.
Vasodilation.
Vasodilation.
Excellent. So this is the trick, guys. So vasodilation, provided the endothelium is functional. But if the endothelium is not functional, what happens?
Decrease blood pressure.
Or what happens to the vessels themselves? No.
Vasoconstriction.
Vasoconstriction, excellent, which is the opposite. That's totally right. Okay, what happens to the lungs, you guys? What happens to the bronchi?
Contract.
Excellent, bronchial constriction. Guys, what happens to secretions overall?
Increase.
Increase or decrease?
Increase.
Increase, that's right, increase. So more secretions. So what happens to sweating, more or less?
More.
More.
Excellent. What happens to urination in general, urination reflex?
More.
Contraction.
Yeah.
Okay.
I think more. Doctor.
Exactly, contraction or more.
Urination is
Okay, guys. Now, yes. Now let's think about those in the clinical context, not in the, only in the effect. Let's think about those if those are good, if those are side effects. Well, if those are clinical indications, مثلا meiosis. Do you think this is a side effect? ولا clinical indication ولا both? What can we use those for?
Clinical indication.
Okay, so meiosis is clinical indication, that's right. But what do we use? Why do we want sometimes the pupil to be contracted?
To the near vision to see the near things. And
pupil, guys, listen. Pupil is not related to the ciliary muscle, so there's two different things.
to not absorb the more lights.
Yes,
think about it. Think about it this way. When there's meiosis or pupil of the eye contracted, the iris, which is the colored part of the eye, will appear more, or the muscle. It will be more visible. Do you agree? It will be larger. When your pupils are small, the muscles are bigger, sir?
Yes.
Okay. So this is good in cases of surgeries for some parts of the iris.
Okay.
And so guys, when someone is having meiosis, light, is it coming in a big amount or not?
No.
Small amount.
Exactly. It's not the case. Okay, so this can be also a side effect where the vision might be impaired somehow. Okay, مسألة. طيب, heart bradycardia. Is this good or bad? Well, it can be both, depending on what I want.
Depending on the
effects.
case.
Exactly. So this depends on the case. Okay, so the heart rate goes down. The vasodilation, what happens when there's vasodilation to the blood pressure?
More blood flow.
More blood flow,
Increase
yes, but
blood
so
decrease
the
blood pressure.
blood pressure will go down, so hypertension. Why? Because the vessels will go bigger. Okay. And because of gravity, the blood will be pulled to the feet. No more blood in the brain. This is why a person will feel dizzy and they will have these side effects. The bronchoconstriction, do we ever want to constrict the bronchi?
No,
No.
Side
we
effects.
want more air to
Excellent
get.
side effects. What
Because
patients?
for some people who have asthma is not good.
Excellent. So patients who have asthma, that's totally correct. All right. What else? Wait. لحظة شوي, I need to just do something. Wait. Okay. What about secretions?
Could be both.
Exactly. Can be both. Okay. Sweating at the same time. Can be both. And urination can be both. Okay. So let's take those one by one. Those are just applications of what I said. So acetylcholine, if it's put in the eye, what's guys intraocular? Intraocular means inside of the eye. Okay. So if intraocular, that means if someone or a surgeon is having a surgery, the surgery requires meiosis. We have meiosis. Okay, now this is something that I have been explaining all the time. Remember when I told you this idea over here? If the endothelium is functional, we will be having vasodilation. If the endothelium is not functional, we'll have vasoconstriction. This is exactly where I want to use this. Now, guys, have you heard of this word before in geography?
Which word?
Do you know what قسطرة is?
Yes.
Okay, this قسطرة is in geography. Okay, coronary angiography is a test that is done usually to the vessel of the heart, coronary vessel of the heart. Okay, over there, sometimes that vessel might be functional normally. Okay, and sometimes the person might be feeling symptoms of something called angina. You know what an angina is?
Yeah, ذبحة.
Flutter.
If you want, exactly. So angina is like a general term for chest pain that is felt because of a heart condition, okay? Vasospastic angina in specific is a condition where the coronary vessel that is supplying the heart usually becomes narrow or small. So the heart does not have enough blood flow, and this causes pain. And how do we check if this is really a vasospastic angina? Usually, vasospastic angina happens when the endothelium is messed up. So I get an angiography, and inside the coronary vessel, I inject acetylcholine. When I inject acetylcholine, if the vessel has a good endothelium, vasodilation will happen, and the patient will feel relief. If the patient, for example, feels another set of strong pain in their chest, that means the endothelium is not good. The vessel did undergo vasoconstriction, and the result is the patient has this condition over here. Is it somehow clear? I feel this is a bit complicated to be given online. So guys, did you understand the idea?
Yes.
All right, so guys, again, this is the case if we have an angina, vasospastic angina, where the vessel of the heart is constricted. How do we confirm this? with the help of a tube that goes all the way to the heart. Okay, and in the tube we inject what? Acetylcholine. If the vessel is good, it will undergo vasodilation. If the vessel is not good, and the case is over here, the vessel will undergo vasoconstriction, and the patient will feel pain. That's the whole idea. Okay. So, second idea is methacholine. Methacholine is a drug also. Let's go back to the table. Methacholine over here is a drug that is resistant somehow. It doesn't get hydrolyzed by acetylcholine esterase as much as this one, but it does small, a little bit. So what do you think the duration of action is going to be? Also short, but slightly longer than acetylcholine. And does it bind to nicotinic receptors? Guys, does it bind to nicotinic receptors? Methacholine?
Yes.
Yes, it does. Yes, it does. So, more resistant to hydrolysis, less nicotinic activity, but at the end of the day, it's still hydrolyzed and it still has some nicotinic activity, okay? What actually do we use it for? We use it for checking if the patient bronchi are sensitive, okay? So we give them in the form of inhalation in the lungs, okay? So some patients have asthma that's not shown. So I give them this drug. This drug is supposed to cause bronchoconstriction. In a normal individual, the patient is not going to suffer from very bad side effects. But if the patient has asthma, the bronchi are going to be extremely blocked, and this is why the patient will feel a very short hypersensitivity in their bronchi. Okay? What else? The two drugs, beta-nicole and carbachol. Both of those are not hydrolyzed by cholinesterase, which make them have a longer duration of action. Whereas, take a look, whereas carbachol is still having nicotinic activity. So can I use this orally in the form of oral dosage forms to target everything in the system? Guys?
Doctor, the network is not good. And I did not hear. Can you repeat it, the question?
Sure. Okay. So my question for you guys is, I forgot. So wait, let me go back. So guys, yes, carbachol. Carbachol is activating nicotinic receptors. When the bronchi activates nicotinic receptors, the carbachol, do you think can we use it orally to target everything in the system? Well, no, we cannot.
No. We cannot.
We cannot.
We can.
Will
Yes, we
affect
cannot.
everything.
100%. They will affect everything, which is not good. Excellent. Okay, so carbachol will not be used orally. Instead, it will be used in the form of eye drops. Okay, to target only the eye. We need to target only the eyes in the case of, so intraocularly in case of surgery. Whereas beta-nicole, okay, so beta-nicole is a drug that is good to be given orally because it doesn't have nicotinic activity. It will only act on muscarinic receptors, which is good. Type. What will it do? It will affect GI and urinary tracts. Guys, what will it do to the GI tract? More motility or less motility? Yes, induced? More, exactly. Exactly, and this is why we use it. Stimulates things, okay? And what about urination, you guys? Will it cause more or less urination?
More.
No.
100%. It was more urination. So this is why, you guys, we use it after a surgery when the person is not able to urinate. And this is what we call as urinary retention. Person cannot urinate, okay? And this happens after surgeries. And this is a case where I can use this drug to help the patient urinate. And I can also give it in patients when they have a small problem in their intestines and in their stomach. Okay, and now we have other drugs. Okay, so we don't use this drug mainly, but those drugs are good for this. Are you understanding, you guys?
This drug is
Are you
selective. It's a selective drug.
So this is selective to muscarinic, was not to M1 or M2 or M3, to all of them.
But you said the muscarinic receptors, they are similar.
Exactly.
So
Exactly.
it's gonna have more side effect if we take it.
Exactly. Thank you. 100%. 100%. 100%. You're absolutely right. Okay, so in a bit we're gonna talk about the side effects, which you already mentioned, Yani, some of those. Okay, some of those drugs are plant alkaloids. What do I mean by plant alkaloids? So those are drugs that are extracted from plants. Guys, do you know nicotine?
What, nicotine?
Do you know nicotine?
Yes, I use nicotine.
Yes, so many of the students use nicotine. So guys, nicotine is a stimulant usually, and is one of the drugs that can affect the CNS. It's highly addictive. And so why am I talking about nicotine clinically? Do we have any drugs that contain nicotine in the market, in the pharmacy?
We have like, yeah, we have, I don't know, we have for addicted
Yes.
people. They are
Yes.
smoking. Yeah.
Thank you, Mustafa. 100%.
let's
So guys,
go on.
sure.
Let's get started to release the nicotine.
Nicotine
the
patches.
Not smoke.
Excellent. We have nicotine patches, we have nicotine gums, we have so many types of nicotine products in the market. Okay, so those drugs will act on nicotine receptors in the brain specifically. Okay. All right, so now you know where do they act in the central nervous system, صح? And we use them for whoever wants to stop smoking. And we have another drug that's called pilocarpine. Pilocarpine usually has a muscarinic effect, and it's used to treat a condition called xerostomia. What's the meaning of xerostomia? Dry mouth. What did we say about those drugs? They cause more secretions. So this is part of a syndrome, you guys. So there's one of a genetic syndrome that's called Sjogren's syndrome. Okay, so this is called, I'm gonna write it down. Sjogren's syndrome. This is one of the diseases that might cause dry mouth, dry secretions, xerostomia. So we give it this drug to enhance more secretions in the mouth. But a major side effect of this drug and all the other drugs is sweating. And if I use this drug in the eye, what will I do? I will be helping with something called glaucoma. Guys, have you heard of conditions of high pressure in the eye?
Yes.
Yes, this is what we call as glaucoma. I think this is slightly hard for us to understand online, so I'm just gonna postpone this in hopes that next time we're going to be on campus, or at least next week. Okay, so I'm gonna define the mechanism of the eye whenever I see you guys. So let's just ignore this for now and then continue later with this. Okay. Muscarine is one of those drugs that is actually a poison, so we don't use this clinically. But what does it do? So guys, can you make sense? out of this? So it causes, take a look, it causes diarrhea. Why does it cause diarrhea? Activate sweat. Increase. Mustafa, you're trying to speak, بس ما بعرف ليه connection is broken. Mustafa, can you repeat what you said?
The motility will be high, right?
Yes, motility of the stomach and intestines. That's right. So diarrhea is caused by that. Type sweating, activation of muscarinic receptors. So more secretions of the saliva. What's lacrimation, you guys? You know? The lacrimal glands, those exist where, you know?
What that?
In the eye. Those are tears. So the person will look like they're crying, saliva's coming out, sweating the whole time, so more secretions overall. And this is one major side effect of these drugs. Okay. Now I have a very special drug, okay, that's called cyvameline. Okay, so this drug is specific to muscarinic receptors, but it's one of the very rare drugs that is specific to the odd numbers, not the even numbers. Okay, so M1 and M3 specifically, and this makes it having less side effects simply because it's specific to some of those. Okay, and guys, this is very interesting for you. Varenicline. What's varenicline? Varenicline is a drug that is, listen, a partial agonist at nicotinic receptors in the brain. So does it make sense that is used for smoking cessation? To stop smoking? So again, what's varenicline? It's a partial agonist. Nicotine, is it a partial or a full agonist? Nicotine, you guys. Full or partial agonist?
Full.
Full.
100%. Sarah, is everything all right on your side? You're saying that someone is removing you from the meeting.
Yeah, every minute.
Okay, so I think it's fixed now. All right, so nicotine is a full agonist.
It's full agonist.
Varenicline, partial agonist. Right? Which one?
It's full agonist because it's related with across the BPP, brain blood barrier, I think.
Nicotine can do that, 100%. Okay,
Yeah.
now varenicline can also cross the blood-brain barrier. Now, what's the difference between those? Nicotine or varenicline is going to block nicotine receptors, okay? Not complete blockade, but usually partial blockade, okay? All right, so this is partial blockade, which makes sense that now when a person is smoking and they're getting all the nicotine will not go bind. Why? Because now varenicline is binding instead of it, and it's giving very partial effect. But guys, question for you. Why don't we use an antagonist? Why am I using a partial agonist? Is it better or not?
Because I need the sensation of the nicotine.
Because of what, Basma?
Because I need the sensation to mimic the smoking sensation. So I need a partial agonist.
Exactly. Guys who smoke here, can you tell me what happens when you stop smoking for any reason?
Withdrawal symptoms.
Withdrawal symptoms. Guys, do you know the withdrawal symptoms of smoking? I'm going to ask smokers, people who smoke, okay? Are you familiar with those?
Headache.
Yes. Especially now in Ramadan, so many people not. Yes.
Yeah. And after you try one, you can have a nicotine rush, really high one, that's make you headache or feel so high. If you get it.
Exactly. It's a headache. Can people focus without the nicotine?
No, at all.
They will lose concentration. So many side effects. So guys, if I want the person to stop smoking.
Hypertension, doctor, also.
Sometimes, يعني, this is because of mainly stress, in my opinion, because the person will be so stressed. No. What happens to the person when I give him an antagonist? Guys, if someone is smoking and I give him an antagonist, they're gonna feel the same effects, the same withdrawal effects. Is this good if I'm trying to help a person stop smoking? Doesn't make sense. Okay, why? Because if I'm helping a person, I don't want them to feel all of those side effects. So this is why I give them a partial agonist. A partial agonist will still maintain some level of activity. So we will be having some activity of the nicotine. But no, the full effect is not there, which makes the persons try to stop smoking slowly. Okay? Usually this is the effect of varenicline that we have, and it's the best drug that can be given for smoking cessation. All right, now guys, this is a table summary for everything we mentioned before. And this is another table as well that is also a summary.
Sorry,
Now,
doctor,
let's
can you
talk
repeat
about
the last?
which one? Varenicline?
Yes, because my internet was not working well and I missed it.
That's fine. Okay, so guys, I want to help someone stop smoking. How do I help them? Do I put them under the stress of the withdrawal effects of feeling the symptoms of withdrawing nicotine?
No, we usually
No.
give them nicotine patch so it can be easier on them.
Exactly. This is one approach. There's another approach that we can give, or in combination of the nicotine patches, we can give them varenicline. Varenicline has a special property that is a partial agonist. So it's not an antagonist. If I give them an antagonist, they will feel the side effects. But if we give them the partial agonist, in the partial agonist, they will not feel the side effects. They will only feel that their nicotine receptors are activated, but partially. So if they smoke, the cigarette is not going to let them feel anything. Why? Because the receptors are already occupied with varenicline, that's a partial agonist. You see now, the receptors are going to be slowly down. Yeah, it's slowly, because of the partial agonist, the effect is going to be slightly less, which makes the person slowly get rid of nicotine.
Okay, thank you.
You're welcome. Okay, now let's
But
go
what
over
about
the
NAC?
What about what?
NAC and acetylcysteine for smokers?
And acetylcysteine?
Yeah.
Well, do they usually give that for smoking?
For smokers, yeah, for cough
cessation?
smokers.
Yeah. Have you? Is it like? Look, N-acetylcysteine is mostly given for the feeling usually
Toxicity of
for
paracetamol.
smoking of their lungs, their mucus built up in their lungs.
Yeah, I know, but
Okay, so this is one of the reasons. And another reason, it's also usually good for dopamine rewards. So it stops this. Do you understand? So it minimizes the cravings. Okay, but it's one of the mechanisms. So people who take N-acetylcysteine will have a reduction in cigarettes per day. Okay, it's a new approach, but it's not one of the major ones that they use in the guidelines. The major ones are varenicline, nicotine patches. There's another one we're going to take in a different lecture that's called bupropion. So many drugs, okay, but it can be used with them, on the side, just to help the patients. Okay?
Thank you, doctor.
But it's not as strong. You're welcome. Guys, know the meaning of a contraindication? What's a contraindication? A contraindication is what is an indication. Indication of a drug is a use. Okay, if I'm using a drug, why do I use it? This is the indication. Okay, the contraindication is opposite, is when I cannot use the drug. It's a contraindication. So when am I cannot use muscarinic agonists? In cases of asthma or a lung disease, which is COPD. And why is the case? The muscarinic agonist, they cause
Contraction.
what do they cause, you guys?
Construction.
Excellent, bronchoconstriction. That's right. Okay, this is number one. If someone is having any form of obstruction in the urinary bladder or GI, okay, why? Because this will be painful, but because now we're provoking more movement of the GI tract, more movement of the smooth muscle, so this is not good.
Doctor, the slides are gone. It's not appearing anymore.
They're not?
No.
Okay, let me fix that.
It's appeared here.
But let me just try to share again. What about now?
I think I have some internet problem. It's not appearing for me.
But guys, is it appearing for everyone?
No, I
No.
can't see.
No. No.
There's no
Not showing at
screen.
all.
No.
That's right. No. Also no? Guys, can you see the slides or no?
No, Dr.
No.
Ricard.
No.
No, Dr. Ricard.
Okay. Guys, let me try to fix the issue. I'm trying to. Last time we still have like a few minutes, so we're just gonna end this in a bit. Just let me just finish like those slides and then we'll be done. So, guys, now I shared my whole screen. Can you see anything?
No. No, I can't see.
No way. It says that you're sharing the we can see. So anyways, so guys, you tell me what happens to secretions of acidity in the stomach, more or less parasympathetic.
More.
More. Okay. So guys, if someone is having acidity in their stomach, is it good to give them those drugs?
No.
No.
No. Okay. So this is one of the contraindications. Type. If someone, for example, already has slow heartbeats, is it good?
No.
No.
It make it worse. Then what happens to the blood pressure?
Will decrease.
Decreases.
Exactly. So hypertension. صح? This is not good for the heart. Why? Because now the coronary vessels will be dilated, not enough blood will reach the heart. Okay, so excessive sweating will happen. So a lot of secretions. Diarrhea will happen. The patient will feel pain in their intestines because they're moving very strongly. The person will feel more urination. The person will not be able to see clearly because of meiosis and then light not going in the eyes. Hypotension is going to happen. So guys, all of the things that you already talked about whenever you were in the room. Okay, so those are the last slides I mentioned. If you're not seeing my slides, that's totally fine. And because we're going to end this now. Okay, so we finished the first part, which is related to the agonists. Do you have any questions, everyone?
No.
No.
All right. So let's just end this session, you guys. Thank you for attending and those who are interacting with me. I know, it's